Hello, good day everyone. I am Prof. Dr. Priya from University Putra Malaysia. Today I'll be talking on PET MRI, the synergy of combined imaging modalities. Firstly, I would like to thank the organizers, Teesside University and UITM, for inviting me to talk at the Emerging Trends in Medical Imaging from Patients to Pixel Symposium. The objective of the talk today is to educate and engage radiologists, nuclear medicine physicians, and technologists on the principles, benefits, clinical applications, and challenges on PET MRI. As an introduction, I will go into the basics of what is PET and MRI. As we know, they are two different imaging modalities. However, it can be combined in a hybrid system. For the purpose of talking about PET-CT, it is a multi-parametric functional and anatomical imaging. We use different radioisotopes to perform imaging in a non-invasive manner to detect physiological, and functional information at a cellular level. The commonest radioisotope that we use, also known as radiopharmaceutical when it's combined with a drug, is 18F fluorodeoxyglucose, or also known as FDG. For MRI, it is an excellent soft tissue detailed software that we can actually scan the human body and have excellent anatomical localization and soft tissue resolution. It does not involve any ionizing radiation and uses multiple functional sequences, including DWI, functional MRI such as fMRI, and also MR spectroscopy. It is a non-invasive imaging, but may sometimes require IV contrast injections. As for the principles of each modality, MR imaging requires a well-controlled and uniform static magnetic field for spin polarization. As we know, our body contains hydrogen atoms in our water molecules, and these hydrogen atoms are precessing or spinning in their own magnetic field. Due to the polarization from the magnet and an RF pulse that is introduced intermittently, the spinning of these protons will change in direction. So this changing in the gradient fields will result in the signal that is encoded in the MRI, giving us different types of imaging appearance. For example, an RF pulse that gives an example of a T1 weighted image, where you can see water is dark, or also known as hypointense, as in the CSF in the ventricles, you can see is dark. This is a T1 weighted image with also dark gray matter in the cortex of the cerebrum, and the white matter is relatively brighter. Whereas in a T2 weighted MR image, the CSF or fluid inside the ventricles is bright, also known as hyperintense. And as you can see, the white matter is darker, but the gray matter in the outermost part of the cortex is relatively brighter on a T2 weighted image. For a flare, it is actually similar to a T2 weighted image, except for the water is darker. So the water is dark in a flare, or also known as fluid attenuation inversion recovery sequence of MRI. The principles of PET is based on the intravenous injection of radiopharmaceuticals such as 18F-FDG. These would produce photons due to annihilation of the positrons inside our body, and these photons of high energy of 511 keV will be generated and will be captured by the detectors of the PET-CT. And these detectors will then capture the signal that is emitted from the radioactivity, and the photomultiplier tubes in the scanner will change this energy into light and electric signal, and then go on to process into an image that we see as the PET image, which can then be superimposed with anatomical imaging. Traditionally, PET imaging is superimposed with a CT scan image. However, in hybrid PET-MR machines, the image of the PET is superimposed onto an MR image for anatomical localization. So the principles of PET-MR is very relatively new. The first commercially available hybrid PET-MR scanners were available commercially in 2011. PET-MRI imaging can be achieved through either sequential acquisition, where the post-processing integration is conducted after acquiring separate scans, or it can be through insertion configuration, whereby a PET detector is inserted in the bore of a standard MRI scanner when needed for the PET-MR imaging. Or thirdly, it could be a simultaneous acquisition where there is full integration of both scanners into a single hybrid system. For the MR that is fully integrated with the PET system, we can see different sequences being performed as the study progresses with continuous PET acquisition. For other principles of PET-MR integration, we see that the system configurations, which is the fully integrated versus tandem acquisition, the PET and MRI detectors are combined into a single unit for simultaneous data acquisition. As opposed to the tandem PET-MR systems, on the other hand, they use separate PET and MR scanners with the patient moving in between them in sequence. For example, they do the PET and then they do the MR with the bed position moving, and then these images are then fused. This tandem type was the first prototype of the commercially available hybrid PET-MR scanners, where two systems were available in one room but put at least 3.5 meters apart. This is an example of a PET scan showing FDG uptake in the brain, and this is a standard this is a flare image where, T1 weighted image, where you can see the fluid is dark and you can see that the white matter is relatively darker, and this image is superimposed with the PET and the MR image to actually get the PET-MR fusion image. You can see excellent anatomical demarcation of the cerebral cortex and see all the gyri and sulci very clearly due to the high soft tissue resolution available in MR imaging, and you can see the functional imaging of glucose metabolism due to the superimposed PET imaging. The advantages of performing a simultaneous PET-MR acquisition can be summarized in S to the power of 2, A to the power of 2, DTC, where there is 2S, 2A, and DTC. S standing for improved sensitivity and specificity, whereby PET-MR for breast cancer staging can have improved sensitivity of up to 95% with specificity of 96% as opposed to a PET-CT. So PET-MR has even better sensitivity and specificity compared to PET-CT for the simultaneous acquisition in detection of breast cancer staging. It also has excellent soft tissue resolution for various solid tumors, especially those that are sub-centimeter and difficult to visualize on CT scan. Also, there is improved alignment when there is simultaneous acquisition, PET-MR imaging, and the image can be superimposed with good alignment, and it is preferable compared to separate scanning sessions. We can also observe a reduced artifact in the simultaneous PET-MR acquisition and reduced dose compared to a PET-CT having a dose of approximately 17.6 plus minus 8.7 millisieverts compared to a PET-MR which did not use any CT for attenuation correction or anatomical localization. It can drop to as low as 3.6 plus minus 1.4 millisieverts in the radiation dose. And this can also result in reduced time of scanning and reduce the need of invasive procedures. However, there is an opportunity to use various MR contrast media in such applications. Now we go on to various clinical applications for PET-MR. Clinical utility of PET-MR includes the utility for diagnosis of complex conditions such as certain cancers, neurological conditions such as epilepsy and dementia, and even heart conditions such as coronary artery disease and myocarditis. The monitoring of drug effectiveness can also be done well using PET-MR. Stem cell monitoring is another upcoming necessity, for stem cells need to be monitored as they develop and differentiate into different body tissues and is best monitored using MRI. Therefore, PET-MR can detect early functional changes that occur during the stem cell therapy. Cancer staging and treatment is also assisted, including staging of brain tumors, breast cancer, lung, and thyroid cancers. It is also a radiation-free alternative, or rather a radiation-reduced alternative, due to simultaneous acquisition of PET and MR without having to do a CT scan for attenuation correction, provided it is a hybrid PET-MR scanner. Furthermore, it is also superior to a standalone modality. This is an example of a patient who underwent gynae oncology assessment using PET-MR. As you can see from the CT scan here, the lesion in the ovaries are not clearly seen due to the relatively poorer soft tissue resolution on CT as compared to this axial T2 weighted MRI of the pelvic region showing the ovaries with physiological appearance of multiple follicles and cysts in both ovaries. And although there is high uptake on the PET-MR imaging, this is actually physiological because of certain glucose metabolism during the different phases of menstrual cycle and in a premenopausal woman. However, with the MR characteristics of multiple simple follicles in the ovaries, we can determine that this is actually a physiological normal finding. As opposed to the images on the right, these images are PET-MR of a patient with an ovarian cancer. The feature on the MR shows a complex cyst with solid and cystic components and a thick wall. These are suspicious features. Furthermore, the solid component of the ovarian tumor has high FDG uptake. And on the MIP image, we can see multiple other uptakes in distant areas of indicating nodal metastasis of the primary ovarian cancer. So this is examples of how there is improved soft tissue resolution in PET-MR acquisition with further potential for reduced radiation dose if a PET-MR hybrid scanner is utilized. This is an example of the evaluation of sub-centimeter nodal metastasis. As we can see in this patient with non-Hodgkin's lymphoma who performed an 18F-FDG PET-MR for staging, we can see large conglomerate lymph nodes in the left cervical region, which shows highly avid FDG uptake, and smaller nodes at the right cervical region. In the MR, you can clearly see the features of the lymph nodes, which have loss of fatty hilum, enlarged and matted. And there are actually multiple lymph nodes with some sub-centimeter lymph nodes that do not take up FDG. So this PET-MR scanning can actually help to better delineate the lesion margin to help with planning of treatment and to also follow up the progress of the treatment. Another example of the utility of PET-MR in a clinical setting is a patient who had abdominal pain. And this patient was noted on MR to have a solid lesion in the terminal ileum. On a gallium dotatate scan, this lesion showed high intense uptake, indicating that this patient had receptors that were taking up the tracer. This is a peptide tracer and was highly suspicious of a neuroendocrine tumor. This patient underwent resection and was confirmed to have a terminal ileum neuroendocrine tumor. So if we just depended on a PET-MR image, these lesions are typically difficult to localize on a CT scan. However, on MR imaging, excellent soft tissue demarcation is noted with good correlation on the PET-MR acquisition that localizes the tracer uptake to the lesion in the terminal ileum. Another example of clinical application of PET-MR is in neuro-oncology, whereby we can see in this patient who had a known glioma on the left side of the brain had a resection. And this scan was performed post-excision of the lesion to detect whether there was any residual tumor. And having this MR imaging actually detecting some high signal intensity in the left cerebral cortex indicates that there is a potential tumor left over post-operative. And this lesion is intense on the FLT, which is an amino acid tracer that is not actually taken up by the normal tissue of the brain, giving a good tumor to background ratio. This shows evidence of residual tumor post-resection of the primary tumor. And we can see some area of gliosis in the region of the resection of the previous large glioma in the brain. And we can also correlate with other MR sequence, such as MR tractography, where we can see abnormal tracts in the region of the previous resection. Now we go on to what are the technical challenges that we may face when we perform PET-MR. The technical challenges include the need for attenuation corrections, because soft tissue attenuation correction for PET images need to be based on an MR image in a hybrid PET-MR scanner. Conventionally, PET corrections are performed using CT Hounsfield units for the attenuation correction. However, in a hybrid PET MR scanner, a CT scan is not performed. So, uncorrected PET data needs to be converted to be attenuation corrected prior to it being able to be superimposed and interpreted on an MR image. This is performed using attenuation correction map based on MR data. For example, a Dixon vibe sequence or T1 weighted fast sequence. The MR-based attenuation correction map is segmented into different soft tissue groups. For example, air group, fat component group, soft tissue group, and lungs group. Then the linear attenuation coefficient or LAC are assigned to these tissue classes in order to derive an attenuation map for subsequent correction of the PET emission data during reconstruction. Resulting attenuation corrected PET scan of the initial data can be seen where this is the PET data and this is the MR data, and then the fusion will occur in order for us to see the PET MR data in one fused image. Furthermore, we need to perform various attenuation corrections based on different patient tissues. As you know, on MR, we do not really see much of bone signal. This is because of reduced photons of water molecules in bones. Therefore, we have to change different LEC in order to correct for different densities of the soft tissue that we are imaging. MR provides information which is based on the proton density and the relaxation properties in a T1 and T2 relaxation times, rather than attenuation of the X-rays of tissues which occurs in a PET-CT imaging. So both air and cortical bone, which lack the MR signal, these are fundamentally different tissue classes that are difficult to separate. Different methods have been proposed to recently improve the MR-based tissue attenuation correction, such as tissue attenuation and scatter correction, which are performed using a 3D Dixon vibe sequence, where the volumes are interpolated with bread hole examination technique, and we can actually provide two sets of images where the water and fat are in phase or out of phase, which help us to determine these interfaces that are having lower signal on MR. Another correction that is very important is the partial volume effect correction. Partial volume effect or PVEs cause under or overestimation of tissue activity concentrations, dependent on the activity distribution and the size and shape of the structure of interest. The signal is not accurately recovered in structures that are smaller than 2 to 3 times the full width height maximum or FWHM of the spatial resolution of PET-CT scanners. The spatial resolution of current state-of-the-art clinical PET scanners is comparable to cortical gray matter thickness, which is about 2 to 3 millimeters for PET MR. Thus, almost all neurological examination will be affected by PVE, but can be minimized using a PET MR system. This is an example of PVE correction, where you can see initially, if you see MR structures, it has very good soft tissue detail, but PET image has relatively lower resolution. However, with the PET PVE corrections, we can actually see the sulci and gyri more sharply defined with good contrast, soft tissue contrast resolution, as seen in this fused PET MR image of the brain post PVE corrections. Finally, let's discuss some future directions of PET-MR. As we know, most scanners are actually hybrid PET-CT and separate MR scanners, whereby patients are scanned separately and fusion is performed in post-processing after the imaging are acquired. However, in hybrid PET-MR scanners, definitely this new acquisition strategy has uh, a lot of time-saving benefits for whole body MR with PET imaging. It also can help improve quantitative imaging techniques with various MR sequences, and it can be used for adaptive radiotherapy planning throughout the process of the radiotherapy regimes, and also with appropriate attenuation correction techniques keep on being innovated, that we can see remarkable future for PET MR scanners. And also, we have newer radiopharmaceuticals for the PET imaging with combination scans that can help to give further functional information. And also, we are looking at future integration with even newer modalities such as photoacoustic computed tomography or PACT, which may be the newer generation of scanners which incorporate even less ionizing radiation using photoacoustic technology. Therefore, we can see in the coming decades marked improvement in technological advancement for hybrid modalities. I would like to welcome for Q&A after this session. Um, and I really welcome feedback and comments from the participants of this symposium. Finally, in conclusion, I would like to share some pros and cons of having PET-MR hybrid scanners. For example, the pros are reduced radiation exposure compared to PET-CT alone, and simultaneous anatomical and functional imaging can be performed using PET-MR scanners for more accurate treatment planning. However, the cons or the limitation for PET-MR hybrid scanners is that these are expensive modalities and not all patients may require a PET-MR, and PET-CT may be adequate in most cases. And furthermore, PET-MR requires high expertise for performing the imaging and post-processing expertise as well as for image interpretation, considering these are hybrid modalities that are interdisciplinary. Ways to overcome these limitations include to perform scans separately and then conduct post-acquisition image fusion. Therefore, we do not need to have the hybrid scanner, but have two separate scanners in a center that can actually be fused imaging post-processing, and this can reduce cost to actually buy a separate hybrid PET-MR scanner. Another way to overcome the limitation is to improve human resource capacity building in hybrid molecular imaging for joint reporting of these hybrid imaging, or even interdisciplinary approach among specialties for cross-training and credentialing in specialties involving hybrid imaging. With that, I would like to thank you, and I pass it over to the moderator. Have a good day, everyone. Thank you again.